next month, right?
Yeah.
Even months, okay. I feel like they come before I know it, it's another meeting again. And we're taping, okay. Should we start? We're going to wait.
Oh, we can.
She said we're starting. She said we're taping.
Okay, you can call. How do I have to?
There you go. It's all good. How many nurses do you guys have? I mean, here.
Oh, we have about 12.
They're kind of looking at that card.
All right, Amanda's going to talk to us about wound care for our pacer pockets.
All right. Thanks for having me. I thought that wound care pacer pockets was a great topic for you guys because you would get them all. I think out of the whole department you have them all. And there are a couple of reasons for that. I don't know how this works. Okay. One of them is that Dr. Brinker is actually one of the few people in the country that removes the pericardial leads. A lot of and you guys I'm sure know more than I know about this, but a lot of places, a lot of times we'll get patients from other facilities where they've taken the device out, but then there's still leads attached to the pericardium with little pathways for bugs to crawl. So they come here and they take them out. And then what we're seeing more is that the EP fellows are starting to close the pockets primarily. So they're suturing them closed. And then sometimes they'll put a JP drain, inferior, sometimes not, it's just closed. And those just get treated like a suture, suture line care, they're pretty easy. But then the ones that we have problems with are the ones left open to heal by secondary intention. So those are the ones that have, an actual pocket. I mean, they're just like a pocket on our shirt, which is, kind of interesting. As far as the most common complications that we see and that we've seen often lately is hematoma formation, and that's usually related to having an acute wound, and then we have to pretty quickly anticoagulate them. So it's a bit of a problem. So you're going to monitor for increased pain, swelling. Sometimes you can see over the course of hours. I'm sure you've all had patients where you can just see it rise. And it doesn't always have necessarily what you think of a hematoma with a bruising look. Sometimes it's just the swelling. If they have an incision, sometimes they're going to start leaking bloody drainage from the incision. And they might have a lot more pain, but not always. Those patients, usually they're going to open up the suture line and wash them out, either in the OR or we'll just kind of putter around with dressings for a few days and just let the dressings do their job to clean out some of that clot. But blood clot can become in and of itself sort of an infected problem. It's just yucky stuff. As far as a complication of a wound infection after extraction, that almost probably never happens. I can't remember a time when it has happened because they're always on antibiotics. And then, of course, pain. I don't know if that's necessarily a complication, but that's something we have to think about. Wanted to talk a little bit about the first dressing change because I've always had conversations with people about this, and I just sort of wanted to clarify. I think we grew up and were taught that a surgeon does the first dressing change. Well, what's different about these pacer pockets is they're not done by surgeons to begin with. So there is no one that's going to come and do a first dressing change physician-wise. They're interventionists. They do their intervention, and they take out the old thing, and then they're kind of done. They do a couple other, looky-sees, but it's up to us to take it from there. So if I'm here and it's about 24 hours later, then, usually me or Joanna, we're happy to do the first dressing change. But a lot of times these things are done on a Friday afternoon, and it's a weekend, and really those dressings do need to be changed, at 24 hours.
Does Jeff usually contact you directly, or is it usually us that contacts you?
It comes through a POE consult.
Okay.
So a lot of times what happens is Dr. Brinker will put in his EP note, consult Amanda Owens, with an S, which I don't have. He calls me Mandy.
Mandy's a miracle.
Right. So that's usually how I get the consult. But it hasn't happened very recently, but there have been times where I'll come in on a Monday and, you know, the same packing has been in since Friday, and it's not packing that's designed to stay in for that long. So whoever has the patient after that 24 hours really needs to do a dressing change. In the ORs, or the procedure areas, I should say, they usually pack them with iodoform gauze. They just use however many bottles of it that they need. So that can be 1, 2, 3, 4 bottles of iodoform gauze, and you kind of feel like the whole handkerchief clown thing, where it just keeps coming, keeps coming. And they pack it tightly for hemostasis in the procedure. You definitely want to pre-medicate your patient. You want to moisten your packing really, really well, and kind of keep moistening it. This is not like where Nurse Hatchett taught you in nursing school, oh, don't wet the gauze. Please, by all means, wet the gauze. Actually, that goes for any wound, because we don't want the wounds to dry out. And then just take your time to remove it. So obviously, it's sort of a pain in your day to have to do that first dressing change, so hopefully it won't happen too often. But it will fall on you. And the next thing is, as with any first dressing change, you're going to be doing that first assessment that needs to be documented. So you're going to want to do just your regular wound care parameters, color, quality of the wound base. Usually these pacer pockets, they'll have a red base, but it's not really going to be granulating yet. So it's just kind of like this red sort of blah looking wound. Sometimes it'll have clot, sometimes not. Sometimes you'll see cautery, which is like little burned areas that look black. And that doesn't necessarily mean it's necrotic tissue, but it's just the cautery chemical will go away over time. You definitely want to measure it and describe the surrounding skin. A lot of these patients, especially if they're elderly, their skin is really fragile, and there's actually a lot of peri-wound skin changes that happen. Just a review of measurements. It's always in centimeters. The standard is that we say it's length times width times depth. Length is always the axis from head to toe. So even though that's going to be the short axis, usually in a pacer pocket, because they're usually little ovals. So it's usually going to be short by long on a pacer pocket wound. And then the width is arm to arm. And then you measure the undermining area by sticking your Q-tip down into the pocket and seeing how deep it goes. And usually, it kind of depends on where they put the incision of the pocket. It's usually above, and most of your undermining is below. But then sometimes they'll do more central, and you've got a little above as well. And then our undermining is going to be using the directions of a clock. So this is not necessarily what a pacer pocket wound would look like, but it's about the same shape. The depth is always just straight in, which is a separate measurement from the undermining, which is sort of down or up or side to side. Does that make sense? Mm-hmm. And it's usually like a free text in the POE, the undermining.
It's not
So
wearing
you
any
just
gloves.
write it there. What's that?
Mm-hmm. It's not wearing any gloves.
Yes, I am.
Yeah, it's just the old nude kind. Although this picture may be that old.
No, it looks like a fingernail.
Yeah. And this is a good picture of just tape injury. So that would be tape denudement. And you can see that it's a perfect square. And we actually see a fair amount of that from the post-op wound dressings. They just put all the stuff on there, and then when you take it off, they have some ripping. So as far as interventions go, you always, it's never specified because our protocol says that we always clean a wound before we repack it. So the easiest way to clean these pacer pockets is just to wet up some 3x3s with saline and kind of tuck it in as if you're packing it and take it out, and do that like 2 or 3 times. Usually the patients tolerate this a lot better than I would ever expect them to, pain-wise. And then the dressings that we use, we used to always use hydrogel gauze. And then what I found was, for one thing, it was sort of a pain in the tush for us to use hydrogel gauze because we had to impregnate it ourselves. And the wounds at first were really, really wet. So we kind of ended up with these really, really wet, soupy wounds that no one thought looked pretty. So I kind of switched my mode of thinking at first to alginate. So I just wanted to make sure you knew, because there's always questions about this too. You guys carry 2 kinds of alginate. This is just calcium alginate rope. So this is just plain old seaweed. There's no silver on it. It's designed to be an absorbent dressing. It's really big. So if there's a really big pocket, I kind of prefer to use this sometimes. Usually what I do before I pack it in is I actually fluff it out. And that's gonna just increase the surface area that you have for
I see lots of
absorption.
lint coming off of that.
Yeah, and you don't have to worry about it because it dissolves.
Okay.
So that's one of the beauties of the calcium alginate is unlike a gauze fiber that does not dissolve and acts like a foreign body, the alginate never acts like a foreign body. Yeah. I don't know if I wanna breathe it, but you can eat it if you want, it's fine.
It's seaweed, isn't it?
It's seaweed, yeah, it's seaweed. Yeah. And then this is the other kind that you guys have. This is it's also called Restore brand, and this is silver alginate. So it also is seaweed. The difference is it's more of a ribbon than a rope. So it's not as convenient to use in a big pocket. I don't care, silver is antimicrobial. I don't care as much about the silver on these wounds as I do about the shape, because they're all on antibiotics. So it's not like you really need to add a whole bunch of antimicrobial, because they're getting plenty of antimicrobial through their IV antibiotics. So it's more like what's kind of convenient to the shape of the wound. If you're gonna have to pack in 5 of these, but maybe we only need 2 of these, this would probably be better and more convenient. Because I'm not about trying to torture you all with these dressings. I wanna make it easier, not harder. The other thing that I consider sometimes is alginate is good for hemostasis. It's not a cure-all. I mean, if there's really active bleeding, it can't stop active bleeding, but it does have this sort of hemostatic property, so if that's an issue, we can use it. But both of these, if the wound is hard to get to the base and you've packed it into like a tunnel that's really tight, it can come apart. And I don't want you to be in a situation where you've lost half your alginate in the base of the wound. So if it's I keep pointing to my pocket here, I'm sorry. So if it's a pocket that you can like dig your Q-tip in really easily, or your finger, and clean to the base of the wound, then I almost feel like you can put whatever you want in there, because you can get whatever you put in out. But if it's sort of a small pocket that there's a concern in the back of your mind about losing a little piece of alginate, at that point we would probably use hydrogel gauze, because you're not going to lose your gauze because it's really strong. All right. And there was a patient that you guys had. He was in that really awesome corner room with all the windows. And he had a hematoma, and we packed him at first with this. But then when I went to see him again, the opening was a little small, and I found myself that it was hard to get out the alginate. So I don't know if you remember what I'm talking about, but we ended up switching him to hydrogel gauze, and it actually worked better for him. And when I talk about hydrogel gauze, have you ever done that before? You know what I'm talking about? Usually what we do, and I didn't bring the Duoderm gel, is you take either 3x3s or Curlex if you need a lot of it, and you kind of open it up and wet it with saline first. And then you squeeze a whole bunch of hydrogel on there and mush it all up. It's called impregnating the gauze. In the outside world, they have hydrogel gauze that's already pre-impregnated, like in 4x4 size sheets. But we have to do it ourselves. So you can see it's kind of a pain to do. It's hard to keep everything nice and clean. So we don't do it quite as much. It takes quite a bit of hydrogel too. Like you could use half a tube to 1 tube per dressing change if it's a big pocket. But it's nice because it's still once a day dressing, and the hydrogel makes it slimy so it doesn't stick to the wound walls. So you want to be more generous rather than less generous when you're using that hydrogel. So once we've done the packing, and sorry, the other thing I just want to say is usually the first few days they're going to drain a lot more. So what we can do is after the first few days, like the first couple days we might make sure it's a daily dressing, but then after that we can start stretching it out. We can still use an absorbent dressing material, but just only change it every 2 or 3 days. So again, trying to be in there less, give the wound more time to close. And then the cover is just going to be whatever's absorbent, dry gauze, ABDs, and then you're always going to want to use this no sting skin prep. So this is what will protect their fragile elderly skin from tape denudement. And also, especially if you're using something like hydrogel that might kind of ooze onto their good skin, it'll prevent maceration. So you can use it all the way up to the edge, and then anywhere the tape will go. I love this stuff. I'm glad you guys stock it. If you have a wound that's draining a lot, you can always change the cover dressing as frequently as you need to, but just only have to change the packing once a day at the most, kind of no matter what's in there. This is disgusting. one of my coworkers did that. Whoops. That's what the alginate looks like when it comes out.